morning. I'm Mr. Nadeem Aslam. I'm a consultant orthopedic smart surgeon specializing in robotic surgery. I'm going to talk about really the anatomy of the knee joint. So the knee joint is a complex joint. It's what we call a complex hinge. So not only do you have flexion extension, you also have a degree of rotation. Now we have to understand what the knee joint consists of. So there are three bones. There's the femur, the thigh bone. There's the tibia, which is the shin bone. And then there's this bone which is surrounded by tendons, which is known as the patella or kneecap. When we go into the joint, we then start to talk about the structures inside the joint. Patients often refer to the term called cartilage. And when most patients are talking about cartilage, they're talking about the meniscus, which is this blue structure here. There are two forms of cartilage. One is the hard cartilage, which is a coating on the joint. So it's on both surfaces, both the thigh bone and the shin bone, and it's about 4 millimeters to 6 millimeters thick on each. That protects your joint and gives you a good space on the x-ray. When your joint starts to wear, it's this coating that starts to disseminate, and it will gradually fade out, and you'll eventually reach a situation that you have bone-on-bone contact, which is what produces pain in the actual knee. The meniscus is like a shock absorber for the knee. It has many functions. One of the functions is, if you can see here, it produces a protective effect on the joint surfaces. It distributes the load. So it's a load transmission. It's a shock absorber. It's also involved in lubrication and controlling the movement of the knee. Now, you can have a meniscal, which is known as the soft cartilage tear. And if that occurs, the patients will present with pain, swelling, activity-related activities. Often the history is we have pain on the inside of the knee, made worse by twisting, turning. At night, if the foot is caught awkwardly. This leaves the other structures in the knee. There's an inner meniscus, which is the medial meniscus, and there's an outer meniscus, which is known as the lateral meniscus. Both are important, and we do need to try to preserve these as much as we can. In the presence of arthritis, keyhole surgery can be unpredictable, and therefore we have to be cautious in those cases and don't generally recommend surgery. But if you've detached this meniscus or torn it, and the joint surfaces are good, then it would be an option. In the center of the knee, you have the anterior cruciate ligament, which is the main stabilizer of the knee, and it prevents rotational movements and backward and forward movements of the knee. And then you've got the posterior cruciate, which is at the back of the knee. Now, we'll talk in detail later on about those structures. We're just going to close the knee joint up and talk a bit about the kneecap. Now, the kneecap sits in the groove of the knee, of what we call the trochlea. In extension, there's no engagement of the kneecap. When you flex the knee at 30 degrees, it engages in the trochlea. And this is an important stabilizer for the kneecap. If you tear the ligaments on this side or you damage this structure, then the kneecap can come out. And generally speaking, it comes out outwards from the knee. And then we've also got the common ligaments on the outside of the knee, which is the medial collateral ligament, and on the outside, the lateral collateral ligament, which can be, when you have a skiing injury or turn or twist, these can be stretched and torn. So we'll talk more in detail about these structures in our subsequent videos in due course.